Are you ready? Thank you. Thank you everyone for being here today, and appreciate you coming to listen to some of my work. As Elaine mentioned, this presentation will be very much in line with the other talks that were presented earlier and will be presented later in this semester at the CRISP webinars and seminars. The main topic is pragmatic research, but instead of anchoring my presentation to the precise criteria, which has been the kind of framework for many of the presentations in the past and will be in the future, I wanted to share with you another aspect of pragmatic research. Basically, a set of loosely connected strategies that implementation scientists commonly call designing for dissemination and implementation. And I just wanted to check in the audience how many of you heard this term, designing for dissemination and implementation, before? Many of you, very nice. Well, what I would like to do today is provide you some definitions and just some basic concepts that you might want to consider in your own work when you are designing for dissemination and implementation. And then, as Elaine mentioned, share with you a series of mini studies that I was able to be part of, lead some of them, which was the testing of a cancer prognostic tool developed by the National Cancer Institute. And it's called now the SEER Cancer Survival Calculator, and it used to be called something different. And it's something that I might mix up the language here, I am sorry. And then finally, I would like to give you a set of resources that you might want to consider if you would like to learn more about designing for dissemination and implementation, including some publications and web-based resources that could be helpful. So in terms of definition, I don't know if this will align with the definition that you had in mind when you heard the term designing for D&I. There are a couple of formal definitions. One that says designing for dissemination and implementation refers to a set of processes that might be considered and activities that are undertaken throughout the planning, development, and evaluation of an intervention to increase its potential to be disseminated and implemented in a later stage. And then the second definition takes it to an even higher level, and it says it could be a set of strategic steps that are taken very early, and you will see that this is really a key piece here, that designing for dissemination and implementation starts extremely early, even when you are starting to conceptualize your research questions. And these processes are there to create and refine your evidence-based intervention, to increase its chances of being noticed, positively perceived, accessed and tried, and then adopted, implemented, and sustained. So it's not only for initial adoption and implementation, but also to increase sustainability. And that's a key piece and a very interesting topic and high interest topic in implementation science right now. So many of the authors that I will offer to you made an attempt to create a set of activities that you can pursue to design for dissemination and implementation. There is not one right way to do this. This is my take on this. I created this to kind of think through in a systematic way the things that I can do when I'm thinking about a new intervention. And so I'm just very quickly going to go through these. Many of you will have already done these activities in your own studies, so some might be new, others might be very familiar. Planning from the start. One thing that comes to mind is including dissemination and implementation as a thought, not just an afterthought, into your proposals, whether it's including in the actual activities, the budget, and also thinking about D&I beyond the traditional publication, presentation at conferences, and have that part of the proposal. Engaging target users is a main topic or a hot topic here at CRISP and around the country. There was I think there were a couple of presentations that included this concept of engagement of stakeholders. What I would like to highlight here is the needs assessment piece, understanding the target adopters and using their input into the development of the intervention, and then throughout the process. And again, I will refer back to PCORI and other much more elaborate descriptions of this process. My kind of favorite topic is the choosing and integrating of theoretical models and frameworks. I really feel that there is a benefit to truly using the frameworks, not just naming them. And many of you are already using frameworks in your work, and others are less comfortable with it. We work with a lot of clinicians where they felt that help from us would be extremely helpful because it's not just traditional way in the clinical world. The behavior scientist will be naturally thinking about frameworks. If you need a dissemination and implementation framework, I will share with you a resource that we recently launched, showing you a set of frameworks that you can choose from. It can get overwhelming. Just within the health topic area, up to 100 frameworks are out there. And so choosing which one would fit to your needs can be challenging, but hopefully this resource will help a little bit. Specifically, if you think about using, designing for dissemination and implementation, the concept of diffusion of innovations and social marketing can be extremely helpful. Specifically, the notion of perceived complexity, compatibility, and relative advantage. Those are very relevant areas, and you might want to consider those. And then from the social marketing area, there are many concepts, but specifically audience segmentation can be extremely important. The other piece that you will see very heavily in the actual mini studies is the iterative nature of the intervention development. And that can be tricky in terms of funding, to find a funder who will accept that you propose to develop your intervention in pieces and go back to your audience and then repeat. But I think that can really improve your likelihood to develop a final product that will be used. Choosing measures that matter in the real world and designs, those are perhaps the closest to the precise criteria, and thinking about those pragmatic choices in terms of both measures and the design choices can be very, very helpful for designing for dissemination and implementation. And then the last one is this: make it easy on future adopters. It's just thinking about what can I do as the original developer of the intervention to make it easy for future adopters to take my intervention and implement it in their own setting. And so in that, along those lines, you can think about toolkits. And toolkits are sound very fancy, but they might be very simple. You might collect all the data that you already developed for your initial testing and just create an easily accessible and user-friendly format for it. So it might include some of the resources that future adopters may need when they are trying to adopt the intervention. It might include some list of budgeting recommendations. It might include an actual business plan that they can use to argue that this intervention will work in their site, or it just inform them which components of the intervention seem to be core components and which are the components that they might be able to adapt to their context. So let me introduce you to this case study. And again, this is going to be a series of mini studies that I was part of. I will be providing highlights, not a full description of each study. And the basis for this is this cancer prognostic tool. Many of you are familiar with the SEER database, which is a population-based database which is maintained by the National Cancer Institute. Recently, the National Cancer Institute is trying to make these population-based databases more user-friendly, easier access for the potential stakeholders, including clinicians, researchers, and patients. And so in one of these attempts, they developed this application, which they initially named CSQS. Now they call it the SEER Cancer Survival Calculator. And what it does, it basically taps into SEER and Medicare data and creates individualized prognostic information for cancer patients. So the patients can enter, and whoever will be the user, because that's one of the questions, age, gender, cancer characteristics, and comorbid conditions, and receive a fairly individualized cancer prognosis for the next 1 to 10 years. And they also provide visuals that can make the assessment and understanding of this data easier. So they use pictograms. And I will show a couple of slides as I'm going through, you will see it. But the notion was that this will make the use of the SEER data much easier for clinicians and potentially patients and their caregivers. Initially, they had prostate and colorectal. Now they added head and neck cancer, and they are finalizing the breast cancer function, and they will be looking into adding additional cancers. Perhaps the one thing I will highlight here, and you will notice it as I am describing the results from our studies, that SEER doesn't have very good data on treatment for cancer. And so the NCI group decided not to dilute their estimates by adding treatment from RCTs or other sources, but they wanted rather to be more precise. And so they don't have the treatment option in here, and you will see how that will play out as we show this to the clinicians and the patients. So this is just a snapshot of what, when you get on the homepage of the SEER Cancer Survival Calculator, it might look like. When we started the testing, it looked very different. And we had only the colorectal and the prostate piece. So that's where we did the testing stages. And most of the changes that they made was based on the feedback that we received from these different set of studies. So thinking back to the designing for dissemination and implementation concepts and the notion of iterative testing, I will not say that we started off with this beautiful, nicely designed flowchart that outlined what we can do. But very soon after we started to work with NCI, we did develop this flowchart and slightly modified over time. We started working with NCI right before phase 1. So NCI did conduct formative research and testing of this idea of developing a tool early on with some physicians and patient advocates. And then based on their feedback, they developed the prototype. And at the time I was working for the CRN Cancer Communication Research Center. It was one of 5 centers of excellence in cancer communication research around the country. It was housed at Kaiser Permanente, Colorado. And we were asked to be the ones who helped them have access to clinicians and actually do the testing. We also had expertise in dissemination and implementation research, and they not only wanted feedback on usability, but also understanding of market opportunities with this tool. So before phase 1, we got into this game and we proposed that we think through together the possible steps for the future and develop this framework. The initial questions that they asked were very simple about current practices around prognostic discussion with patients, what kind of tools they might use, what kind of resources they have, and what do they think about potentially developing this tool. And so that was the feedback that led to the prototype. Following that, we conducted the first set of interviews. And so at this level, we had again 2 foci. One was usability. How does this work in the clinical practice? Let's see whether the clinicians actually like it. And then the second one was, how well could this be adopted or implemented in different healthcare delivery systems? And so you see the pragmatic research angle coming in immediately. We are concerned with various types of clinicians and various types of settings. We conducted interviews around 4 settings. One was the Kaiser Permanente, Colorado, our natural setting. We came to the university, and so the University of Colorado participated, the VA, and Denver Health. And then within those settings, we had various types of providers. We had physicians, we had PAs, nurses, social workers, and the pharmacists as well as psychologists participating in the interviews. We wanted to get a sense at which level of healthcare this could be best used. And then diversity was also brought in terms of specialty and primary care. We wanted to see various specialty care feedback. So we had surgery, oncology, GI, and radiation oncology and radiology included. And then we also had primary care because we thought, well, if primary care physicians will be involved more in care for cancer patients and survivors, they might use this tool really well. And we conducted 57 interviews across these 4 institutions. They were 90-minute interviews, and they included 3 main parts. First, we asked about what are your practices in terms of communicating about cancer prognosis with your patients? And then what are your resources and what are your problems and barriers? And then we had them use the tool. And we developed case studies. We didn't want them to use their own patients. So we had case studies for prostate and colorectal cancer, and we had them enter those, and then we usability testing, and then we also recorded these sessions. And then we also had a set of questions afterwards that focused on implementation potential. How would this tool work in your practice? Who could use this tool? Would you recommend this tool to someone else? So very typical D&I types of questions. And we learned a lot from these interviews. We learned about some typical usability problems that they encountered. They were obviously not major ones because this was a very well-tested tool just by the developers, but they were related to how well this tool fits with clinical practice. They made recommendations about terminology, the output of the data, the color schemes. So really very broad range of changes. And then the other types of data that we learned was would this tool work in your practice? And overwhelmingly, we got positive feedback. They thought this is a great tool, easy to navigate. It would be it's very quick to enter the data. But thinking about my clinical practice, I would like this tool to communicate with the EMR and pull in the data automatically. And I would like this tool to be actually pre-fed with this data when I sit down with my patient. They also said that not having treatment information will make this useless for most of the clinicians who are in the specialty field, because they felt that comparing a patient who got treatment A and treatment B is perhaps the most important clinical question they have. Having a baseline understanding of prognosis and being able to compare whether the patient will die of their cancer or their comorbid condition is a very interesting concept, but it is not necessarily the major question they try to answer in their clinical world. And so those are two critical pieces that we had to communicate back to NCI. And they did make major changes on the usability and interface based on the feedback. But these two pieces that were perhaps the kind of deal breakers within the healthcare delivery system were not ones that they could address immediately. And so moving to and this is just one change I wanted to show. So this is the original version of the output that they receive. You can see how 1, 3, and 5 year prognosis is displayed with these figures and the opportunity to change the people chart to a pie chart, etc. And this is the revised version. It's kind of easier to see according to the clinicians and the feedback based on from the stakeholders. It allows for comparison of various types of patient scenarios in one session. And so this is just one change that they made based on the feedback. But again, once we heard from these clinicians, and in addition to the clinicians, we heard also from some operational leaders, we realized that bringing this tool to the clinic in terms of integrating with the EMR and including treatment option will not be a route to take. So we had a very deep discussion with NCI about their priorities, and they still felt that releasing the tool to the web, to the patients, is not appropriate. This is because it was not designed for them. And clinicians also said that the current language would be very inappropriate for patients. So you would have to redesign the interface. So they still wanted to go forward and explore further. What if we make this tool just available on the web to clinicians? Are they going to use it? Some of you might be familiar with Adjuvant Online. It's an online web-based tool for prognosis. They thought, well, why don't we do the same thing with this tool? And so we proposed to conduct a small-scale implementation study across diverse sites and see if we give the web address basically to these clinicians, are they going to go and use it in their practice? And in this second round of study, bigger study, we actually contacted the university. We realized that the patients here, the types of cancer patients they see, will be not really appropriate for the tool. And so we ended up not including the university. Instead, we worked with Kaiser, and we went to the Penrose Cancer Center. They are rural, urban kind of service. And we also included 2 private practices. So this is the first time we are taking the tool to the private practice. They were urology practices, and we asked them to consider using the tool. In the process of making it available to them, we tried to use practices that are in line with traditional way of learning about new tools. So we didn't want to do anything extreme that NCI could not replicate by releasing the tool. We identified some champions. We talked with them. We asked them, how do your clinician colleagues learn about new clinical tools? They said it's mainly during department meetings or cancer tumor boards. And so that's what we did. We came in, we introduced the tool. We had the clinician, actually the champion clinician, talk about it a little bit to the group. And then we left them with the tool. We did have follow-up activities that were all initiated by the clinician. By sending a follow-up email or a voicemail, depending on each practice, how they usually do follow-up reminders. And one of the practices actually at Penrose, they decided to use the tool regularly in their tumor boards to introduce it more in depth to their other clinicians. And so we certainly, this is kind of the initial implementation strategies that you can see here, how many rollout meetings we participated in, how many follow-up emails were sent out. The other activities might refer to a clinician meeting with another clinician, the champion clinician meeting with another clinician in the hallway and mentioning the tool. And so we asked them to always email us when those happen. And so you can see that there were a number of activities, and you can see that the 158 providers were reached in some ways. We created login information for them because we needed to track somewhere what they were doing. So in the background, they were tracking their actual data entry, but we didn't do any other activities to interrupt the normal flow. And well, the results were fairly disappointing. Initiation of sessions within the tool happened, and the data pools indicate 30-day kind of increments. So you see we are following here 3 months. So initially we see a number of case scenarios, 30 across these number of sites. And then ongoing, there's 15 more, 6, 1 nicely kind of dying off, despite of the follow-up activities. So after about 3 months, we communicated this information to NCI, and we together decided not to go through the 6-month follow-up, but rather use the leftover funds to test the tool with patients. And so we did have some follow-up interviews with the champions, and we learned about the most important barriers. We realized that not having integrated with the EMR is a big problem. The treatment is a big problem, lack of treatment option. But it's also a problem that they don't get any incentives for using this tool, and that in general, their usage of prognostic tools is not very high. So this is really not only just a new tool, it's a new concept. And most of the people who use the tool, they used it in their own offices, not with the patient. They felt that it would break the patient and provider communication flow, which is a wonderful thing to hear that they consider that as a problem, but it was a problem for the tool dissemination. And we did hear from many of them that this would be wonderful to give this to the patient once you develop a patient version, because the patient could bring it in, and I would be happy to discuss the results with the patients here. And so that's kind of the message we sent to NCI about potential release. And while they didn't give up on potential integration within the healthcare delivery system, and they are working with small providers and developers right now, how it could be integrated with EMR or the treatment piece brought in, we started to work with them more on the patient-facing version. And so I just wanted to share a few findings from what we heard from patients. And again, this is the first time actual cancer patients interact with the tool. For the recruitment of these patients, we initially wanted to work with the Kaiser cancer patients, but we had some logistical issues. So we ended up actually contacting 2 patient advocacy groups, and they are wonderful. I really warmly recommend both groups if you are in need of cancer survivors for your studies. One is the Prostate Cancer International, and the other one is the Fight Colorectal Cancer. And these folks obviously are going to be a little bit different than general cancer survivors. They are going to be more technologically savvy, they are going to be more knowledgeable, but they are also going to understand a little bit more other cancer patients' needs. And so we conducted 7 interviews for each cancer site, so 7 colorectal, 7 prostate, using a case study. We quickly learned that the patients really wanted to enter their own information into the tool. And it actually happened on the first 2 interviews when I learned about it from my project manager, who then never did it again, but it was an interesting learning that the patients wanted to know what their numbers would be. And so we didn't want to do that because we didn't have the additional support in case they wanted to discuss this with a clinician. But we just defaulted to a case study that was close to their type of condition. So we worked with early and late stage kind of prostate case studies. And for the colorectal as well, we had adjusted for gender, etc. So these are just example case studies. And these are the participants in terms of distribution of age, race and ethnicity, their stage in terms of at cancer diagnosis, and then how many years passed since their cancer diagnosis. So there is some diversity and some, there is no racial diversity here. And one of the patients identified both as white and non-white. So that's kind of what you see there, 7+1. I am sad to say that Michelle Henton, who conducted most of these interviews, left Colorado just this morning to join PCORI, which is a wonderful career move for her, but she's not here today to share the great experience she had talking with these patients. And these patients were wonderful. They wanted to share the information. They were very knowledgeable. They did regard ourselves as patient advocates for others. And they talked about their role in different support groups and their role, what drives their patient advocacy activities. They also talked about what kind of information they currently use in terms of obtaining cancer information and prognostic information, and it's really much in line with what you find. They do use the internet. They trust their doctors most often, but they often read before they meet with their doctors, and they bring information to those meetings, so they are very much activated patients. And they also, it seems like the doctor is still an important source of information despite of the prominence of the internet now. And in terms of, we also asked them about, do they prefer getting prognostic information in terms of numbers or words? And there is a mixed kind of feedback. Some feel that I prefer words. I don't want to hear, I have this many years to live, or this likelihood of living for the next 5 years. I would like to hear, I have a good likelihood to live in the next 5 years. And others felt, I do want the numbers. I do understand numbers and percentages, and I would like to get those. Again, I am just being very broad here. We have much more detailed data and also from clinicians on this. In terms of the tool, overall, they felt that the tool was easy to use, but the terms and the language is the big problem for patient users or potential patient users. So if NCI is going to release this on the web to make it accessible for patients, they do have to do something to support the understanding of the terminology. And that's tricky because, I mean, how easy you can make certain cancer diagnostic, terms. And so, again, here is a place where NCI is struggling. We can link in glossaries, but it is going to be a highly technical form that they have to fill out still, because they do have to understand their staging, and they do have to understand comorbidities, and they do have to enter those. So that's kind of a tricky piece. They also mentioned some limitations. They were very savvy about their own cancer, so they knew that if, for example, the colorectal cancer calculator is only limited to a certain age group, it's going to leave out a certain other age group. They also felt that lack of treatment option is a problem. And finally, they liked the visual output, and they provided very clear input on what should change on those outputs and some other functionalities of the website. So it says, I would like to make it easier to step through the process. On the first page, it would have said, click here to begin the tool, click here to go next, click here to continue. So it's just very clear navigation ideas that they had. They also helped us thinking about implementation related issues. Would you have any concerns about making this tool available for patients? And some felt this can be tricky. If patients have direct access to prognostic information without the presence of a healthcare provider, this can really make them anxious and distressed. Others thought this is an information that people already discuss. And so, yes, just make it available to us. And so this is the point where NCI is really hesitant making the tool available, because they are nervous. What will happen if a patient finds out that their prognosis is really bad? And then some actions are being taken by the patient that are not favorable. And so this kind of helped them understand. Most of the patients did fail, though, that they are ready to understand this data and access it. In terms of would this tool be better prepare them to discuss prognosis with their provider, they definitely felt that this could not only help them better discuss this topic with their provider, but also to discuss this topic with their family members. And then in terms of what stage of the diagnosis or the cancer care journey they would want to have access to this tool right off the bat at all stages. And finally, would they recommend this tool to others? And the answer is yes, mainly newly diagnosed people. And that's appropriate use because this is for newly diagnosed people. And so this is the last piece that we communicated to NCI. At this point, they are working on revising the website and creating the patient version and hopefully releasing it on the web in the next few months. The initial development of the tool was 2008. We are in 2015. They are very careful, they are slow, but that doesn't usually happen with tools like this. They usually get put out on the web. And I will show you how many other tools doing the same thing are already out there. And they're also working on the other pathway still of trying to figure out how could this be promoted to healthcare providers. And as I mentioned, they work with small groups of developers who can help include it into the EMR, include the treatment function, and some other major issues that were raised. So what did we learn from this CSC experience in terms of designing for dissemination and implementation? First of all, our work was done by early engagement of various stakeholders, and that was true throughout the process. And I think that made it extremely helpful and powerful. We did use an iterative process. This was a luxury, basically. The funding that was provided for the study was very small. They really lucked out with a junior investigator who cost really little money to be able to do this much work for that much amount that they basically devoted to this and getting that much data. But the iterative process was obvious, and they were very open to change the tool and then bring it out again. They actually asked us whether they should test it one more time before they put it out to the patients. And then the measurement and documentation of DNI and stakeholder relevant outcomes was throughout integrated in this process. We looked at, we tried to look at outcomes that would be deal breaker for clinicians and understanding whether the tool. One piece that we don't know yet, and that's something that we'll have to figure out, is this really changing patient outcomes? If you use this tool, are you going to see more patient satisfaction, better cancer outcomes? And that's always hard when you do such a small intensity intervention, because how are you going to peel this off from other activities? Guidance to future adopters and implementation was definitely provided. And then we used an interdisciplinary collaboration in the study team. I mentioned that we used human factor design analysts. We worked with programmers. We had epidemiologists on team, behavior scientists, implementation scientists, and then obviously the NCI folks who were both communication researchers and statisticians. And so the input from all of those groups was very helpful. And then in addition to that, we were able to do some extra activities. We were able to do a systematic review of all cancer prognostic tools that are on the web. We identified 22 of them, and so we created a review and published it. And based on that review, we developed this interactive tool that helps clinicians pick the prognostic calculator that would be best for their current patient need. And so this is one tool that is now available. And then we were also able to do a Kaiser-based external validation of the algorithm that runs within the tool. And so we published 2 papers in the JNCI just recently describing this external validation and looking at how cancer patients at Kaiser act differently or utilize healthcare differently based on their cancer and comorbidity prognosis. So basically we just classified them using the tool algorithm and looked at what kind of health utilization patterns we could see prior to diagnosis, year after diagnosis. And obviously this is a descriptive study with all the limitations, but it was an interesting exercise to use the algorithm for a different purpose. So I will share with you a few resources that you might be able to use if you think that designing for dissemination implementation is something for you. There are a number of publications out there that describe this process much more in depth and much more appropriately than I did here. One is by Jim Deering about biomedical interventions and how you are designing for, he uses the term diffusion, but it's basically DNI. Another one by Russ Brunson in the public health arena. He's talking about designing for dissemination among public health researchers. And so that's another great piece if you are in the public health area. And then the third one is the cancer communication, but I think it would apply to a broad range of health services and public health interventions, authored by Deering and Kruter. And so again, they are describing these various strategies that you can use to improve your likelihood to be adopted and used. A very early piece was the development of a planning tool done by ARC. Not many of us are familiar with it. They provide kind of a template to think through the process of dissemination. And you can find this online, free access. Our group developed the Make Research Matter website, and within that there is a planning tool where you can enter information about your planned intervention, and it will give you a tailored report. So it's basically not doing any miracle. It's having you think, it's prompting your brain, what kind of things could I do in my intervention planning to do a better job for DNI? And then the actual tailored report could help you frame your proposal section on dissemination planning. And then knowledge translation planning template, a wonderful template. It's a hard kind of copy thing. It's not an interactive one, developed by knowledge translation colleagues in Canada. And again, you can download it from their website. You can fill it out. It's very simple and quick, and it can give you, again, just kind of a probing and brainstorming tool to think about partner engagement and partner roles. And this is a little bit longer than what you see here. This is just a piece. And then I mentioned my love for DNI frameworks. So this is our brand new website that we just launched through CRISP and ACORDS. And this is basically a tool where you can go in and see all the models that are relevant to health related DNI research, all in the sense that all the ones that we found and were able to abstract. Currently 84 of them. We know that there are others that will come. So you can do a couple of things. You can go in and add your, or inform us of another model that you know of and we didn't include here. You can search these models by different constructs and characteristics of the model that you might want to have and get a list of models that would meet your criteria. You can have some strategies on how to adapt and integrate models. And then the big work that we did was abstracting constructs of all the 84 models and then create kind of a unified terminology. So you are able to search the models by constructs now and also see what are the specific elements that they use in their models. And then we linked these to measures whenever appropriate. Measures. Our current work is to put out a paper on repositories for pragmatic and DNI measures. One of them is the GEM DNI, actually, but there is also the CIRC instrument review project. And if you log in, actually, you are able to access now measures that they rated and described very well. And these are not just DNI measures. These are, in general, behavior and health services measures. So you might want to review this. And then there are some other resources, including the CFR, the Consolidated Framework for Implementation Research, and they have a coding guide, so that's more for the qualitative piece. So that's all I had for today, with the acknowledgement of a lot of people around the country and here in Colorado for the contributions. I actually wanted to specifically mention Russ Glasgow, who is here and who was throughout the process very helpful when he was at NCI, Kaiser NCI, and then here at the university to make this series of mini studies possible. And then a person who actually was very helpful here in Colorado and not listed here because he was mainly connected with the website is Chase, who is sitting here, and he was the one who put the final touches on the website and made the launch possible. So that was really helpful, and thank you so much. So this is just to finish up my presentation. I'm sure many of you are familiar with this cartoon now, but this is really getting you back to the designing for dissemination and implementation concept and how important it is to have the different stakeholders engaged to get the product that the customer really needed. And so with that, I will stop here, and I would love your input, recommendations, and hear about your work that might be relevant and look for collaboration opportunities. Thank you. Go ahead.
So you and I talked about this, but my struggle with your example was this was a tool that I assume was validated, so that there's so it works. It actually is pretty accurate in predicting survival. Is that what makes it evidence-based? Because typically then you want to implement, interventions that are evidence-based when you do DNI.
Yes.
And maybe a related question is, because you mentioned this, we don't know if it has an impact on patient outcomes. So why was that not critical ahead of time to establish efficacy of this tool to change outcomes?
always hope that this question is not asked by the audience, because this was a question underlying throughout the process. But let me just step back, and this is an excellent, obviously, and a very good observation telling me that you are now an implementation scientist, because this is a very important, I think that it is the key question. When is an intervention ready for implementation or dissemination, and when do we have enough evidence? And I think it's a very soft area where we, in some cases, people feel that they need the evidence with the particular tool, with the particular audience in the particular setting. And in other cases, we feel that it's sufficient to say that a similar type of tool using the same kind of framework or concept with similar, audience or a different audience seem to work. And we have enough kind of evidence to believe that this tool would work with this new audience in this new format. I think for me, the helpful piece is the hybrid study design paper by Kern and colleagues. I don't know if you are familiar with it. They describe the type 1, type 2, and type 3 implementation studies. And they basically differentiate the level of evidence and when you can conduct those different studies. And they provide you with a criteria when you am I ready? For this particular tool, we can argue that we know that decision aids in clinical practice are helpful to explain certain concepts to patients, and that the SEER database has highly valid information, and that the algorithm they used had internal validity before they developed the tool. And so the combination of those evidence, we might argue, is enough to just go ahead and distribute this tool. As other people felt that it's, if they develop a prognostic tool, the other 21 that we found, it's okay to just put it out there. You can also argue that there are other tools doing this out there and they are not doing as good of a job because they are not validated or they are not using a reliable data set. And so I think that there is a little bit of a wiggle room as long as you can argue using some sort of criteria that this is ready for implementation, you will be okay. And that's why I kind of point you to that current article, and I don't know if we have looked at it together, to look at that criteria, whether you can argue that, yeah, we have other interventions that are similar, or we have tested this with a group of people and there is not that big of a change. And I can argue that the core components are the same. And so I think that there is a little bit of a wiggle room of that, but when your review will come, they are going to question, as they did with yours, whether it's ready for dissemination or not. I don't know if I am fully answering your question or revealing more confusion on my part. Yeah, that's perhaps the closest for any kind of like criteria that says, A, B, C, D, you are ready for type 1, type 2, type 3. I don't know, Elaine, are you familiar with anything else that?
It makes me think also about the point you raised earlier, the difference between it was maybe scientifically validated from an epidemiological standpoint, but it hadn't really been validated from a clinical use standpoint. And so the things that you raised, which were feedback from the consumers of it, relate back to what's the relative advantage or usability of this information, right? They make wonderful scientific arguments and comparisons, but the kinds of decisions and comparisons I'm doing in real life with a patient is maybe not validated. And so it might illustrate a blind spot in that sometimes we as scientists or agencies, they say, I do have validated scientific data, but they might not be framing it from the context of their consumer, their user, when they're thinking about that.
Exactly.
Right?
Yeah. But then you come into this other angle where they have the SEER as being the evidence-based, intervention, the SEER database, and then now you are just developing this dissemination strategy of making it easily accessible. So it depends on what kind of angle you put on this, and I think that that's in some ways the trick, because truly what is the outcome of the usefulness of this particular tool? It's just so low intensity, and you are not going to see really clinical outcomes change, I don't think. And that's tricky with many of the low intensity DNI kind of strategies.
I'm wondering, this was excellent. This was very nice to hear what you had to say. I'm wondering if NCI thought about, if you were in a real world situation trying to market this, you would have a sales force that's, I know you've got champions, et cetera, but you know that there's a lot they really, do you think, get a sense of what they needed to invest to support it? You know, it's not just a bill that it will come, but rather any product launch needs a lot of active, you know, is that sales force? It's the, you know,
Yeah, I think that what they were. Yeah, I think that they do say that we are not a for-profit institution and we don't have those resources. Hence, I'm going to engage communication scientists and implementation scientists and hope to learn from them something that will replace that effort. And what we learn is it's not going to replace it, because why do people use adjuvant online? Well, it's a good question. We don't know. It was not studied. It's not used very broadly. But if it's used, I mean, what is the magic piece here? And we don't know.
I know in the drug side they'll call it academic detailing.
Mm-hmm.
Essentially, it's using that kind of construct, but it's at least there's a recognition that you need to invest in research.
Yes.
Even if it's an academic detailer, it's still a force that's out there
Yep.
engaging.
And that was, I think, the reason why we didn't see implementation as much, because we didn't use anything that NCI could not use, and it clearly didn't work. Going into a meeting and presenting a tool, and even having a champion say, you know, yeah, you know, this is good. It's not enough. They need constant reminders. They need that academic detailer to show up and remind them, and incentives for initial use, and then it might stick. We don't know. Yeah. Any other thoughts? Anyone else who is struggling with similar problems or?
Are these slides maybe available? I didn't write down all the references fast enough.
Sorry.
So the talk will be uploaded with the slides. So within a week? Yeah, I think that. So if you go to the site, you can, you know, point people to it if you wanted to share it with colleagues. So if you were, I'll ask this because I work in the area of drug safety, and oftentimes companies are coming forward to, in some ways, use decision aids like this, but they often have no pre-testing of it.
Mm-hmm.
So if I were to say, well, you're just being too academic to request it, right? If you could wave your magic wand and go back to the beginning, how fast could you have done it, even in our own academic world, and how much money would you need to do some of the pre-testing that you did? I know you said that it was not very much funding, but how, you know, what, if someone wanted to start moving forward in budgeting, to do this sort of cycle that you've done, what should they think about? Kind of taking out the time it took for NCI probably the process.
Yeah, that's a tricky question. I have never gone through this exercise. I might do that in the future. The actual data collection is tricky because of the clinicians being so busy. And I didn't mention perhaps very explicitly, but we did use incentives to have 75 clinicians agree to talk with us, and it was $100 per person. So it was fairly, you know, substantial. And I have never added up the actual, you know, amounts that we received across these multiple studies. I would say less than $500,000 for all the studies total. And time-wise, you know, we took a lot of years just because we had to go back and forth on the proposals. But I think it is reasonable to say that you could do this within a year. Yeah.
I think that would be very helpful somewhere to get that out, because a lot of people who are trying to adopt this approach will say, well, that's too rigorous. And really, you know, $500,000 sounds a lot to us, but in certain settings, that's not that.
Yeah, and you know, if you are a little bit more targeted and you can make this a little bit tighter. We collected a lot of data more general about information-seeking behavior, etc., which is helpful for, you know, a researcher and interesting, but not necessarily directly informing the usage of this tool. It could have been done before the tool was even developed.
So what about in terms of funding for like strategizing to write an R1? I wrote down some notes about you can almost carve out phase 1 and 2 and do that before you submit an R1. Is that what you're seeing? I mean, do they want like there's a lot to be done with the agency, right? With all the different phases. Is it better to go in and say I'm going to do all these phases, or to go in and say I've already done the first 2, now I'm getting plans to do the next? I mean, are you seeing patterns or trends?
Well, you know, this was funded through our center, which is again not completely generalizable situation, and it was their product that they wanted to be tested. So that changes a little bit their willingness to, you know, invest. I feel like going in with a product that we developed and telling them we want to test this and we want to do all those phases, it would be not possible. They would want to see some preliminary data. I don't know what level of preliminary data, but starting where they started, I don't see that would be very easily possible from an external perspective. The engagement piece, right? Well, the engagement grants might fit into this because it's truly.
But then again, you've got to think about the engagement gets framed as I'm working with patient community. It does not get framed as much as I'm working with healthcare community or provider community. Now, that doesn't mean that you can't. I'll just raise this, and I should not go with because have you heard of action grants from ARC? Okay, so this is a series of grants that have been by ARC to promote dissemination, adoption of, I guess, of evidence, right? And they've had a series of these over the years. So I think a more recent one, you're familiar with the surgical checklist that is done for patient safety and so forth. They had a whole series of development, very similar to what you're describing here. So our center here at Accord is put in to be one of, again, you have to be one of the preferred vendors. And I think we should find out in next month, this is Mark Wright's, it's done in February or March. That might open up, then these things become task orders, right? And there seems to be a process by which you can at least propose thematic areas that might need this dissemination. Now the challenge is they don't have unlimited funding probably for all project ideas, but that might be something, if it gets funded, we can share amongst the Chris Lister community and maybe have Mark come in and give maybe a brown bag lunch around what is it, et cetera. There might be researchers here who might be interested in engaging. I think part of the challenge is that what you've done is so beautiful. This is how product development is done, right? It took a little longer. And yet our grant cycling is set up to be done as research studies. And so the challenge is how you get these opportunities to really do product development in there, because that's what now the real world does.
Yes. No, I think that it is perhaps not a most generalizable example from the perspective of repeating. I was just trying to show some operationalization of these concepts of designing for D&I, but it's a tricky one because of the type of funding that is available. Well, thank you so much.